Hello and welcome to Radcliffe Cardiology's webinar in association with Arrhythmia and Electrophysiology Review and European Cardiology Review. I'm Harriet Seeger and I'm delighted to be joined today by Dr. Dan, Head of Internal Medicine, Clinic and Cardiology and Electrophysiology Department at the Karol Wojtyła University of Medicine and Pharmacy in Bucharest, Romania. Today, Dr. Dan is going to be talking about non-antivitamins K oral anticoagulants, otherwise known as NOACs. In the last few years, emerging NOACs have been used in patients with non-valvular atrial fibrillation as suitable alternatives to warfarin and vitamin K antagonists to prevent stroke and venous thromboembolism. But it hasn't been without controversy. Dr. Dan will talk us through the advantages of using NOACs and the possibility of tailoring individual NOACs to the patient. Dr. Dan, welcome today.
Thank you.
Thank you so much for joining us, Dr. Dan. And just a quick note to our audience, you'll have the opportunity to ask questions via the text box on your screen throughout the course of the webinar, and Dr. Dan will answer as many as possible at the end. Okay, so I'm going to stop talking now and hand over to Dr. Dan.
Thank you. Thank you, Harriet. Good afternoon, everybody, and welcome. I'm Dr. Dan from the University of Medicine in Bucharest. You have here my disclosure of interest, nothing linked to this presentation. So, you know that non-antivitamin K oral anticoagulants, or NOACs, emerged as one of the most revolutionary and expected cardiovascular therapeutic class at the beginning of our century. After almost a decade of clinical experience, the new anticoagulant therapy is accompanied by many practical questions and challenges. For today, after a short introduction, I propose a talk on 9 practical issues. It means the elderly patient, the atherosclerotic vascular disease, patient with cardioversion, patients prepared for ablation, patient with isolated episode or valvular heart disease, or a secondary prevention stroke, patient on warfarin, patient programmed for surgery, the bleeding patient, and the last but not the least, how to choose between different NOACs. Let's begin with several introductory words. As you know, NOAC define non-antivitamin K oral anticoagulant and the new class, but different from the warfarin, NOACs act directly on different vulnerable targets, the so-called coagulation cascade or so-called coagulation cascade. This fact could imply potential clinical differences between NOAC molecules. The Apixaban, you have seen here, act on the activated factor 10, and the Dabigatrans act on factor 2 thrombin. Now, there are 3 available Apixabans, Apixaban, Rivaroxaban, and Edoxaban, and only one Gatran, Dabigatran, after the withdrawal of the Gatran a decade before. The clinical efficacy of, for stroke prevention of all NOACs was demonstrated by important randomized control trials comparing the new molecules with the already certified warfarin. All these trials were initially powered as non-inferiority trials. However, some of them demonstrated superiority in several regards. Overall, several meta-analyses, and you have here, they produced the biggest one from the RUFS meta-analysis, demonstrated that NOACs are superior to warfarin regarding stroke and systemic embolism. You should remember that Dabigatran 150 milligrams was the only to demonstrate at this dosage a superiority, a significant superiority for ischemic stroke. What is maybe more important is that regarding the safety, especially regarding the devastating intracerebral hemorrhage, all the new anticoagulants demonstrated superiority. Apixaban showed also statistical significant improvement in mortality. And finally, all were positively involved in reducing major bleeding, So therefore, the clinical profile of NOAC is superior to warfarin, both in terms of efficacy and safety. And this is the point from which I want to begin my discussion. What about the elderly patient? Atrial fibrillation is very prevalent in the elderly. Up to 1 in 10 persons above 75 have atrial fibrillation and are exposed to the stroke risk. The question is, are NOACs safe for such persons? In fact, all NOACs demonstrated in subgroup analysis that the result of the main trial applies also to the elderly patient. For example, the Dabigatran 110 milligrams showed similar safety and efficacy in, versus warfarin in patients aged above 75 regarding stroke and systemic embolism, major bleeding, at the price of slightly increasing in gastrointestinal bleeding, the same result shown in RELY overall with 2 dosages. The consistency was also demonstrated for patients above 80 years. And you can see here that this is consistent with the results below and above 80 years. Consequently, the low tested dose of Dabigatran, 110 milligram, is recommended for elderly and very elderly. For the patient, we should, below 75, we should remind that the dosage of 150 milligrams was that demonstrating superiority in terms of reducing ischemic stroke. Therefore, this dosage should be preferred in such kind of patients, in all patients below 80, if they have normal or only moderate altered renal function, balancing each time on clinical grounds the risk for strokes on Charles-Watts scale and the hemorrhagic stroke risk score on the Heart-Blood scale, stroke risk. For patients above 80, and we have such patients in our practice, the 110 milligrams Dabigatran, so the low dosage is recommended, and also for the patients younger than 80 if they are on verapamil because of drug interference. The second important question, what about the patients with atherosclerotic disease? You know that atrial fibrillation is more prevalent in the aged patients, and so many have atherosclerotic vascular disease. The first issue is if your patient requires a stent, which is a problem. The problem is that for thrombosis prevention in PCI patients, you need double antiplatelet therapy with aspirin and usually clopidogrel or other P2-IGA12 inhibitor. For stroke prevention in atrial fibrillation, you need oral anticoagulants. So in such patients with atrial fibrillation prepared for PCI, you need a triple therapy of oral anticoagulant, aspirin, and clopidogrel. This problem is not a trivial one. As up 1/3 of atrial fibrillation patients suffer an acute coronary syndrome and need stent implantation. And the need of triple antithrombotic therapy increases considerably the hemorrhagic risk. We have some ideas, some alternatives, as suggested by the WEST trial. In WEST trial, oral anticoagulants, warfarin, plus clopidogrel, was associated to significant reduction in major bleeding and no increase in thrombotic events, including intrastent thrombosis, versus triple therapy. So the question is, such a double therapy would be preferable in patients with atrial fibrillation and programmed for PCI with acute or stable coronary disease. Unfortunately, the study was too small to impose a definite conclusion. The only study who showed us some ideas about the patient on new oral anticoagulants, or better, the antivitamin K oral anticoagulants, because they are no longer news, and double antitherapy is a RELY study, because as you can see in this slide, in ROCKET, in Aristotle, or in ENGAGE, for Rivaroxaban, Apixaban, or Edoxaban, the patients receiving concomitant double antiplatelet therapy were excluded. So the only information for the trials we have came from the RELY trial. In any case, we should emphasize that the data we have about the NOAC therapy in patients with triple therapy is quite limited. And you can see from the subgroup analysis in the RELY trial that addition of antiplatelet agents to anticoagulant therapy, doesn't matter warfarin or novel or non-antivitaminic K anticoagulant, NOAC, increases significantly the bleeding risk, even more with warfarin than with Dabigatran. There are ongoing studies testing not only the best regimen on the PCI patients exposed to triple antitherapy, but also the regimen of patients exposed to PCI and who should have also the antiplatelet therapy from the newer classes of antiplatelet therapy. And you have seen here the Redual PCI trial with Dabigatran, the Pioneer AFI PCI trial with Rivaroxaban, the Augustus acute coronary syndrome PCI trial with Apixaban, and finally the planned Evolve AFI PCI trial with Edoxaban. Until the result of this trial, until definite decision, now the decision is based on clinical grounds. This is apparently a busy slide published by Greg Lipp 2 years before, but it is based on a very simple evaluation philosophy in 4 steps. First, the estimation of the stroke risk by means of the Chatzwas scale. Second, estimation of the bleeding risk by the Hasbled score with the cutoff point of 3, as was shown in the guideline. And the third step, is deciding on the clinical grounds if the patient is an acute coronary syndrome or the indication is a stable coronary artery disease patient. So finally, in the step 4, we have to program different periods of anticoagulation for triple or double antithrombotic therapy. As you can see here, this period could last for 6 months or shorter, with total therapy, combined double of triple therapy for 1 year. What is important, after 1 year, all patients should be on oral anticoagulants. The newer practical guide published by European Society of Cardiology and European Heart Association by Heilbuchel and collaborators is based on the same philosophy, with a very clear suggestion of shortening or lengthening the period with double or triple therapy based on supplementary factor, as it is the atherothrombotic risk for the patient or on the type of the stent used. If it's a first generation stent, of course, we should prolong a little bit the period of triple therapy. Is a new generation stent, this period could be shorter. So this diagram, which is a simple one, you can find it in the published guideline on NOAC, explain, and it's a practical base to use NOAC on top, or NOAC on top of double or triple or double antiplatelet therapy. So as a conclusion, for the patient undergoing PCI and triple therapy, the choice could be if warfarin or NOAC. Warfarin, if the patient is well controlled, this means a time intrathecal range above 70% with INR in the range of 2.5. When we have to choose NOAC, the lower tested and listed dose is preferred. This means, for example, 110 milligrams for Dabigatran, 2.5 milligrams for Apixaban, the lower dose for Rivaroxaban, and so on. There is no preference for a NOAC over another, as there is no study head-to-head to prove superiority of or inferiority of one or another of NOAC. If the patient has a stable coronary artery disease, the therapy in this patient, and this is very important issue, should be monotherapy with NOAC. Why NOAC? Because the superiority in efficacy and in safety, and it's applicable to all NOACs. Only a minority of patients should add aspirin to NOAC because in these patients the risk of bleeding is increasing by adding aspirin. This is very important, as many registries demonstrated an overuse of aspirin on top of oral anticoagulants in patients with concomitant stable coronary artery disease. A problem which was not tested yet in a special study is the patient with stable peripheral artery disease. Again, the preference is the monotherapy with NOAC. Why NOAC? Because of the superiority in efficacy and superiority in safety, and applicable again to all NOAC, and no particular NOAC can be favored over another because the lack of studies head-to-head. Again, in very selected patients, for example, in significant carotid artery disease, aspirin could be added to the monotherapy, again, on the risk, on the price of increasing the bleeding risk. Another problem is the patient referred for the cardioversion. The guideline is very clear in this regard, and it indicates electrical conversion for unstable patients and on elective basis. It is well known for everybody that the efficacy of cardioversion is by far superior to any of pharmacological conversion, including the newer vernacular. What is important, conversion to sinus rhythm is encumbered by increased risk of stroke, regardless of conversion modality, including spontaneous conversion. This embolic risk is roughly for 10 days for atrial fibrillation, which is recent, less than 48 hours, and it lasts until 1 and 1.5 months if the atrial fibrillation has an history for more than 48 hours. So, oral anticoagulation has a proven efficacy in decreasing embolic risk. And you can see here from a very important study published in 2011 that conversion to atrial fibrillation to sinus rhythm is associated with a risk of thrombotic events, and the incidence of embolic events after cardioversion is less than 1% if the adequate anticoagulation used. You can compare here the risk of thromboembolism in patients with anticoagulation and without anticoagulation, and you can see the difference. This study demonstrated overall risk of 0.5 versus 4.6, but in other papers maybe the risk is a little bit higher. So the limit of 1% is the risk assumed by use of oral anticoagulation. There are several problems several challenges, some of them still unsolved with cardioversion. The problem is if the fibrillation is longer than 48 hours, we need anticoagulation for several weeks, and this predisposed to atrial remodeling and atrial fibrillation perpetuations. And so the question is, are NOAC equally safe and effective as warfarin in pre and post procedure? Are there trials to demonstrate this, which is the situation in daily practice? Could we shorten the periprocedural period for elective conversion? We have some indirect evidence, for example, from the RELY trial. The RELY trial included the highest number of conversions, and subgroup analysis. The analysis demonstrated that practically there are similar rates of stroke and systemic embolism in patients converted with or without transesophageal echography before conversion. You can see the results are somewhat superposable on the global results of the RELY study. The guidelines indicate that for the patients with atrial fibrillation of a duration longer than 48 hours duration, or when the duration of atrial fibrillation is unknown, WAC therapy, including warfarin or Dabigatran, is recommended for more or at least 3 weeks prior and for at least 3 weeks after cardioversion, and this is a recommendation of class 1. In patients with risk factor for stroke or atrial fibrillation recurrence, oral anticoagulation therapy, whether with warfarin or a NOAC, and this is no difference in here in this recommendation between NOACs, should be continued lifelong, and this is a gain of class 1 recommendation. There are several ongoing studies with Apixaban, the eminent study, which is more palpable is the X-VERT study recently published. In the X-VERT study, it was a randomization of patients in 2 strategies. Early strategy with the patient evaluated by transesophageal echography, and delayed strategy comparing Rivaroxaban with warfarin, with the aim to demonstrate non-inferiority in Rivaroxaban before and after cardioversion, in early cardioversion and also in delayed cardioversion. The patients were randomized in the rate 2:1. What is interesting in this study, the patients or the result of the study was divided in several populations. It was an intention to treat population to analyze. It was a safety population to analyze for all patients receiving more than 1 dose of study drug, and it was a modified intention to treat population, primary analysis set, in patients without demonstrated left atrial or appendage thromb by transesophageal echography. As you can see, what important point in the result of the X-VERT trial, that the number of days until the cardioversion is shorter in patients treated with Rivaroxaban versus patients treated with warfarin. Then explanation is very simple, because anticoagulation was more effective in these patients than in patients treated with warfarin. The other phase of the same thing is that the number of patients with inadequate anticoagulation was much lower in the Rivaroxaban group than in antivitamin K group. The study was not enough powered for the primary endpoint, which is a composite of stroke, transient ischemic attack, non-central nervous systemic embolism, myocardial infarction, or cardiovascular death. But there is a trend of superiority. This is a trend of superiority of Rivaroxaban compared with warfarin, as you can see from this slide. Unfortunately, the confidence interval is not enough to confer a statistical significance to this result. So, in patients prepared for cardioversion, the oral warfarin remain the standards of care, but there are a lot of available data to suggest the NOAC are safe and effective alternative, as shown in an excellent paper published by Hans-Christoph Wiener in European Heart Journal 1 month before. We have no enough data to compare between different NOACs in this regard. Another problem is the patient referred for atrial fibrillation ablation. It is known that ablation is a hope because if the patient well chosen, the control and establishment of the sinus rhythm is achieved in 60 to 80% of patients, especially with paroxysmal atrial fibrillation. The process is much lower in patients treated with drugs. Doesn't matter the drug, with amiodarone on top of this. But the ablation is not without risk, and this is a small but measurable risk of complication, including tamponade, stroke, and transient ischemic attack. So it is very clear that we need anticoagulation strategy in this patient. Some data from the different centers demonstrated that in low-risk patients, so it means CHA2DS2-VASc 0 or 1, 30 of patients are anticoagulated on referral and they continue anticoagulation, and 70% are naive and they could start NOAC. In the patient with higher risk, this means CHA2DS2-VASc above 1 in men and 2 in women, 80% of anticoagulated are anticoagulated on referral, and they continue or can be switched to a NOAC. 20% are naive and they start NOAC with at the time of the ablation. There are several proposed strategies in patients with ablation. One is interrupted warfarin with bridging with low molecular weight heparin, as you can see here, with an interruption of 24 hours before and after when bridging with low molecular weight warfarin. Another strategy is uninterrupted warfarin. And finally, it is the third strategy of minimally interrupted non-oral antivitamin K oral anticoagulants for 12 hours to 24 hours before and after the procedures. All these strategies were tested in different small studies. What is very important to point in this moment is that the bridging therapy, this means interruption of warfarin and bridging with low molecular weight heparin before and after the ablation, is accompanied by increased embolic and hemorrhagic risk. So bridging seems to be an unacceptable alternative at this moment. So the majority of authorities do not advise for bridging, and bridging probably will become an historic strategy in this regard. Dabigatran, Rivaroxaban, and Apixaban were tested in small studies compared to warfarin in such kind of patients. And we have several small conclusions. For example, in patients treated with NOAC, we need larger doses of heparin during the procedure because it lasts longer to reach the active thrombin time. There were reported similar rates of stroke and major hemorrhage in patients on warfarin on NOAC. And what is important for Dabigatran, it were reported fewer minor hemorrhages than with warfarin. You can see here Dabigatran compared with warfarin were compared in three different strategies: uninterrupted therapy, interrupted therapy, interrupted Dabigatran therapy versus uninterrupted warfarin. All these small studies, you have here the citation, demonstrated similar rates of thromboembolic and bleeding complication with Dabigatran versus warfarin. Again, you can see here from a direct study published in Pacing in PACE in 2014, the bridged therapy is associated with an increased risk of hemorrhage and less protection for stroke than treatment with Dabigatran, which probably is the most suitable therapy in this study. Recently, it was published a position paper of European Heart Association about this issue, and there are several very clear recommendations. One is that in patients receiving vitamin K antagonist, warfarin, the ablation should be performed without interruption of vitamin K therapy. Uninterrupted NOAC therapy may be considered in some patients undergoing ablation, probably in patients already on NOAC. In patients receiving a NOAC with a normal renal function, it is reasonable to give the last dose 24 hours, 1 day before the ablation. During the ablation procedure, patients should receive unfractionated heparin to achieve an ACT of more than 300 seconds. Oral anticoagulation should be continued at least 2 months after the ablation. Subsequently, the decision of oral anticoagulation depends on the stroke risk of the patient, in fact, on the CHAT risk. If the patient is a CHAT risk above 2 in men, 2 in women and 1 in men, probably the therapy should be continued lifelong. A new study, aimed to evaluate Rivaroxaban for a patient referred to AF ablation for early strategy means with the control of transesophageal or intracardiac echography versus delayed strategy, randomizing Rivaroxaban versus uninterrupted vitamin K. A comparative study is a recircuit study which compares Dabigatran with warfarin, trying to demonstrate the non-inferiority in terms of safety and efficacy of Dabigatran versus warfarin. What happens in real life with patients after ablation? As you can see here, the decision is driven to the estimation of the stroke risk with a limited numbers of months of oral anticoagulation with low stroke risk. This means of 0 or 1. In patients with higher stroke risk, as was demonstrated by a paper from European survey published by Tanya Potpara last year, this is a chronic administration of anticoagulation. So exactly what happens with patient without ablation happens in patient with ablation after the ablation, depending on the stroke risk. We have no enough evidence at this moment that in ablated patient, the thromboembolic risk is substantially lower than in patient without ablation. So the recommendation made by Diener and et al. In the paper already mentioned is that the first choice is probably because of the accumulated evidence of uninterrupted warfarin. But the second choice could be Dabigatran, Apixaban, or Rivaroxaban. Edoxaban was not studied yet in this regard. The bridging is the third choice for these authors. For me, bridging is by no means an alternative. Several small questions about the patient with a single isolated atrial fibrillation episode, or the patient with valvular heart disease, or the patient who is in the case of the secondary prevention, he or she already suffered a stroke. For the single documented episode of atrial fibrillation, the consensus is that there is no need for oral anticoagulation, warfarin or NOAC. So generally, we do not anticoagulate a patient with a single documented episode of atrial fibrillation. But I should remember that the choice of type of the oral anticoagulation is not influenced by the pattern of atrial fibrillation and the frequency of atrial fibrillation of number of atrial episodes. So the statement of no anticoagulation applies only to the single documented episode of atrial fibrillation. You know very well that all NOAC were studied only in non-valvular atrial fibrillation. And the American guidelines from 2014 and the new guidelines from NOAC use define valvular atrial fibrillation as severe mitral stenosis or prosthetic valve. So we have no evidence for such patients. And because of this, the first choice and the only choice in the patients with moderate severe rheumatic mitral stenosis or mechanical prosthetic valves is and remains warfarin. Nor Dabigatran, neither Rivaroxaban or Apixaban or Retrospective should be used in this setting. However, we have some small evidence from analysis from the Aristotle trial, which shown that in patients with mitral stenosis, because in these studies several patients had mitral stenosis, valvular diseases, Apixaban is superior to warfarin. You have here warfarin in valvular disease, and here you have Apixaban in valvular disease, with green. And you can see that there is a superiority of Apixaban versus warfarin. But these data are not enough to recommend any NOAC in the setting of mitral stenosis, severe mitral stenosis, or prosthetic valves. For the other valve abnormalities, because of indirect evidence, Apixaban and Rivaroxaban may be used. This includes mitral regurgitation. And the second choice could be Dabigatran or Endoxaban, and this classification is based not on direct studies, but on indirect evidence from the studies. A very important problem is the patient who already suffered a stroke and is now in the situation of secondary prevention. It was very clear shown by ESUS study from the early 90s that oral anticoagulants are more effective than aspirin for secondary prevention. And I emphasize this because unfortunately in practice we have a number of patients in secondary prevention on aspirin instead or being on oral anticoagulation after ischemic stroke provoked by atrial fibrillation. And this is practically a non-treatment for these patients. And we have this data from the early 90s. In the studies with non-antivitamin K oral anticoagulants, the incidence of ischemic stroke was very low. And you can see here for all the NOAC, Dabigatran 2 dosage, Rivaroxaban, Apixaban, and the Endoxaban 2 dosage, the incidence of ischemic stroke was very low. The only trial to demonstrate a significant decrease in isolated ischemic stroke, so not in composite endpoint of ischemic stroke, embolic non-cerebral stroke. So the only to demonstrate the significant specific decrease was Dabigatran. However, almost all other anticoagulants showed a benefit in secondary prevention. You have here for Dabigatran 120, 150 and 110 that this is an absolute risk reduction of 0.71. It seems low, but it is very high because the incidence is low. So Dabigatran is superior to warfarin in secondary prevention as it is in primary prevention. Unfortunately, this is not the case of Rivaroxaban, who failed to demonstrate a significant difference in prevention in secondary stroke prevention. But Apixaban, like Dabigatran, demonstrated also a significant decrease compared with warfarin of the endpoint of stroke or secondary transient ischemic attack. There is also a meta-analysis. This meta-analysis was published in 2012, demonstrated that overall, especially based on the Reliant and Aristotle, there is a trend toward the benefit of NOAC for stroke and systemic embolism, and significant benefit in hemorrhagic stroke versus warfarin. So we have in sum an efficacy benefit, a trend of an efficacy benefit, and a very clear benefit in safety, especially regarding the devastating hemorrhagic stroke. I would emphasize that even in patients very well treated with warfarin, you have here the patient in the superior quartile of the patients treated with warfarin with the ideal time in therapeutic range. Even for this patient, NOAC seems to be superior to warfarin, and this is a study made comparing Dabigatran with warfarin. So these are for me enough to understand the recommendation of the American guideline published in 2014, which conferred to Apixaban and Dabigatran an indication equal to vitamin K therapy. Level of evidence is 1 for both therapy. In my opinion, if we have to choose for secondary prevention, as NOAC have proven superior in efficacy and superior in safety, this could be the choice. One delicate question is when to resume the anticoagulation after a stroke, because it is very well known that a stroke is accompanied by hemorrhagic peristroke risk, and this hemorrhagic transformation is healing modality of the brain. The simplest is to apply the dinner rule, 1, 3, 6, 12 days after the severity of stroke. If the transient ischemic attack, the anticoagulation therapy could be resumed after 1 day. If the mild strokes, 3 to 5 days. If the moderate stroke, 1 week after the stroke. And if it's a severe stroke, of course, in comparison with MRI examination, the anticoagulation should be resumed after 2 weeks. One important point here, maybe less known, is that therapy with warfarin in primary or secondary prevention is accompanied with increased risk of stroke in the first 30 days. It was very elegantly shown in this paper published by Laurent Anzulay in European Heart Journal 2 years before. So this is another reason for which I prefer NOAC to warfarin in patients with secondary prevention. Therapeutic challenge is represented by so-called cryptogenic stroke and ESUS. ESUS means embolic stroke on undetermined source. We know now that a quarter of the strokes are so-called cryptogenic, so it is not a clear cause. In the last years demonstrated that a number of these cryptogenic strokes are in fact silent atrial fibrillation. So these patients are prone to anticoagulant therapy. For the ESUS, the situation is less clear, and for the moment, for the ESUS, the strategy preferred and recommended is aspirin. An ongoing study will answer to the question if the aspirin strategy is superior or equivalent or inferior to Dabigatran in the respect ESUS study comparing in a randomization Dabigatran to aspirin in patients with a stroke defined by ESUS, and you can see here that the definition is very strict based on the MRI and CT. What about the patient already on warfarin? What to decide if your patient is already on warfarin? The first problem is to assume, to predict if the patient will have results on warfarin. It depends at least on the possibility that the patient can keep the INR control and to have a time in therapeutic range above the ideal 60 or 70. There is a score which is called SAM-TTR score. You can see here the score, including 1 point for sex, age below 60, famous sex, 1 point for medical history, at least 2 of the hypertension, diabetes, coronary artery disease, peripheral artery disease, heart failure, previous stroke, pulmonary, hepatic, or renal disease. 1 point from treatment with interactive drugs, for example, amiodarone. 2 points for current tobacco use, or 2 points for race, for non-Caucasian race. Patients with TTR score between 1 and 2, between 0 and 2, between 0 and 2, are likely to remain event-free and are a prediction of well-controlled antivitamin K therapy. In fact, the study demonstrated that above 1, there is already a risk of poor control of INR. So, in a patient with a SAM-TTR score above 1 or at least above 2, indication for NOAC seems to be very rational. Again, from the paper published recently by Diener, you can continue the vitamin K antagonist with careful monitoring, especially if the patient preference is in this direction. A second choice, or I may better say alternative first choice, is to substitute vitamin K therapy with NOAC, especially assuming the superiority in efficacy and in safety in this patient, and especially in patients with SAM-TTR above or equal with 2. And also, the patient preference is very important in this regard. For beginning this therapy, we should have an INR below 2 for Dabigatran or below 2.5 for Rivaroxaban, as was shown in the primordial studies with these agents. Very debated question is, what about the patient with so-called low stroke risk of CHA2DS1 in males or 2 in females, because the female gender is already a point in the CHA2DS consideration. There are a lot of evidence in this moment demonstrating, and I cite the last year paper of Greg Lippen, co-workers, and other analysis published in JACC, that CHA2DS1 is a risk. So the indication and the recommendation of first choice is to anticoagulate this patient, and probably the new atrial fibrillation guideline expected this year will be in concordance with this recommendation. Also, the new anticoagulation and especially naive patients should be preferred in this kind of patients. So please anticoagulate patients with CHA2DS2-VASc of 1 males or of 2 females. Several small discussion about the concomitant therapy in patients anticoagulated. There are very few interaction with non-antivitamin K oral anticoagulants, different from warfarin, but still there are several. For example, we should decrease the dose of Dabigatran or Rivaroxaban in patients taking verapamil because interference in these patients in 2 target points with verapamil. No dose reduction is recommended in patients taking Rivaroxaban. And Apixaban also do not interact with amiodarone and verapamil. Dabigatran is contraindicated by RCP in combination with dronedarone. And in this patient, edoxaban could be used as we have the evidence in last years. One of the last delicate problems is the patient referred for surgery and patient with bleeding. One interesting point to emphasize here is that an argument in favor of NOAC is a less bleeding risk in the case of need for the early surgery. In this study, you can see if the surgery is programmed for less from 24 hours or 24 to 48 hours, the bleeding risk in patient on Dabigatran, it is a paper published by Haley in 2011, is less than on warfarin. So, novel anticoagulants confer increased safety versus warfarin in patients who are programmed or planned for surgery. There are 2 different problems in patients planified on acute surgery, urgent surgery, or on elective surgery. If the urgent surgery, 2 things should be kept in mind by the practitioner. One is renal function assessment, as many of the novel anticoagulants, like Dabigatran, for example, are dependent of renal function. So the dosage should be correlated with the estimate of time of elimination using the Cockcroft equation as it was used in trials. The other is availability of the clinical, hospital, practical coagulation test in order to determine if the patient is still under the influence of oral anticoagulation. Of course, for warfarin, we have the INR, which is a good mean to monitor the patient. Unfortunately, the situation is not similar for NOAC. For Dabigatran, probably is the most favorable profile because we have available clinical tests. I'm referring to activated partial thrombin test, APTT, which give us qualitative information about the dosage, and the diluted thrombin test with a quantitative determination. And many hospitals have this, at least these 2 tests. The heparin test is quite expensive and not available in many hospitals. But APTT and diluted thrombin test, activated partial thromboplastin test and diluted thrombin test are available. Unfortunately, for anti-10 activated factors, we have not available usually a direct test in many hospitals, which is direct anti-factor factor 10 assay. And we have only indirect results, qualitative results, with prothrombin time for Rivaroxaban. For the elective surgery, the NOAC should be interrupted depending of the pharmacokinetic properties. For example, in Dabigatran, if the renal function is normal and or superior to 80 milliliters per minute, the standard in the patient with standard bleeding risk, the anticoagulant should be stopped 1 day before the procedure. When is a high bleeding risk, 2 days. For the patient with moderate alterated renal function, there are the same indication. For the patient with severe alterated renal function, the NOAC should be stopped 2 days in standard bleeding risk and 4 days in high bleeding risk. I emphasize that Dabigatran is contraindicated in patients below 30 ml per minute. This regimen was tested in several studies. One is those cited here, published by Schulman in 2015, and you can see that it goes. The primary outcome of major bleeding was very low, of 1% in these patients. Again, bridging is not concealed at this moment for this patient, as it increases the risk for bleeding without decreasing risk of thromboembolism. What about the bleeding patient? One good news is that even in patients who suffered a major bleed, the prognostic on new anticoagulation is better than on warfarin. It was demonstrated in recent analysis, and you can see here that the Kaplan-Meier estimates in patients on warfarin is worse than in patients on Dabigatran after major bleed. The majority of the reported bleedings with NOAC are mild and moderate and respond to usual maneuvers, with mechanical maneuvers, with charcoal if the drug was recently administered, with endoscopic hemostasis, etc., etc., platelet transfusion. For a selected number of patients, the hemorrhage could be severe, and we have here to administrate recombinant factor 7 or coagulation plasma combination of plasma concentrate of coagulation factors. The good news that after the less or more psychological pressure, now we have available, and it enters the indication, the first antidote. In fact, it is not an antidote, it's a reversal, because the term antidote refers usually to the poisons. So it's a reversal agent to Dabigatran. And are ongoing reversal agents for the anti-10 also. But the reversal agent for Dabigatran, idarucizumab, was already tested, and this agent had several clear advantages. Acts immediately, provides complete reversal of the drug, provides a sustained effect, has predictable effects, has no pro-coagulant effects, it's easy to use, and specifically targets only the Dabigatran. And because it is a humanized, human part of antibody, the allergic reaction are minimal. So practically this agent takes the NOAC out of the equation. It is very easy to administrate in the practice. It was tested in the reverse AD trial, which is the first trial with specific reversal agent, which tested the patients in two groups. One are patients with uncontrolled bleeding treated with Dabigatran. The other are patients with Dabigatran planned for emergency surgery. What can we see from the result of this trial, because there are many? One is the patients included in this trial in both groups, the patients with severe bleeding on Dabigatran, patients and patients with indication for emergency surgery. The profile is quite the same with the real life. You can see here for the first intracranial hemorrhage, trauma, gastrointestinal hemorrhage; for the second, bone fractures, cholecystitis, acute appendicitis, etc., etc. And what we can see from the trial in the group A, the median maximum percentage of reversal in 4 hours was 100%, so a complete reversal of the agent practically in both groups. So it is very efficacious, it's very easy to administrate, and it practically responds to the psychological and the practical problem right when the NOAC appeared first on the market. Maybe the most difficult and most tricky question is how to choose between NOACs. Why this question? Because NOAC belongs to anticoagulation class, but they are composed by different molecules acting on different targets. There are different pharmacokinetics and ancillary properties with different modalities of laboratory testing and with different results from the randomized clinical trials, real-life evidence. On the other hand, we have one of so-called advantages of NOAC are the few dosages for the patient, only 2 doses for each drug. But one fit all may be not exactly the most appropriate strategy for our patients. And finally, maybe a psychological reason, with many molecules on the market, there is a physiologic interest to choose. For the moment, you have here what we have. We have Dabigatran 150, 110, because in Europe, the 75 milligrams dosage was not approved. Apixaban 5 and 2.5, Rivaroxaban 20 and 15, and Doxaban 60 and 30. When comparing the study, we should take in account at least 2 things. First, the protocol. All Rivaroxaban, Apixaban, and Doxaban were based on the double-blind, double-dummy study. RELY was part of the probe, what it means, prospective, randomized, open-blind endpoint study. But we should emphasize that in RELY, we had a very low number of dropout, and the time in therapeutical range was very close to optimal. Also, the second thing, to look at the patients. In RELY and in Aristotle, we have different kind of patients. In Rivaroxaban, the patients usually are severe patients, and this is important in choosing one anticoagulant or another. Which are the main issues when we try to compare the NOAC? First of all, the safety, gastrointestinal bleeding, renal impairment, age. And second, the adherence to therapy, comparing one daily versus twice daily. We have no time now, it is already late to discuss all this, but we should emphasize there are no head-to-head studies. Therefore, the efficacy and safety cannot be assumed on the evidence. There are subgroup analyses, but no of the subgroup analysis is powered to demonstrate inferiority or superiority. And what is important, in fact, even for the available dosage, there is not randomization except the RELY study, which randomized the 2 dosage. For the Rivaroxaban, only 1/3 of the patients supported the lower dosages, and in the Aristotle trial, only 428 patients were on the low dosage. This could help the practitioner to choose. Also, the effect on the renal function should be emphasized. Dabigatran is contraindicated the renal function below 30 milliliters per minute. Apixaban could be offered in patients with function between 15 and 30 milliliters per minute, but in general, these patients are quite unstable. There is not a general agreement. There is not a guide. I present here only one from 5 or 6 proposals of individualization therapy. It is a proposal by Greg Lipp and Hans-Christoph Diener, based on indirect evidence and the judgment of different results from the study. For example, in the patients with secondary prevention recommendation could be Dabigatran, because the effect of Dabigatran in such kind of patients. In patients with moderate renal impairment, Apixaban or Dabigatran can be used in different dosages. In patients with coronary artery disease, the authors recommended Dabigatran because in the RELIGHT study, this is the only NOAC studied together with double antiplatelet. But here there is also another problem, you know very well, about the myocardial infarction and Dabigatran, which was solved in the last year. Again, in the aged, the recommendation is low dose of Dabigatran or low dose of Apixaban. In patients, based on preference of patient and in patients with willing of having good adherence and preferring once daily dosage, of course, Rivaroxaban or retrospective could be recommended. Again, this is not a guideline. This is not an agreement, and probably the answer to the individualization will belong to the future. I stop here. Thank you for your attention, and I am waiting for your question. Thank you very much.
Fantastic. Thanks so much, Dr. Dan. It's absolutely fascinating, and it's clearly not a one-fits-all situation. We have had a few questions in from our audience, so I'll fire away. The first one is, what is the impact of medication non-adherence in the personalization of NOACs?
No adherence is very important for warfarin, as it was demonstrated, but it's also important in NOAC. Theoretically speaking, NOAC were created to increase the adherence, but I can say that this is a sword with two edges, because in NOAC, adherence is even more important than in warfarin, because if a patient escape a dosage of warfarin, there is a little impact on the coagulation. But in a patient taking Dabigatran or Apixaban or Rivaroxaban, escaping one dosage has a tremendous impact on anticoagulation, so expose more the patient. So adherence is very important for NOAC, and this is why it is very important that the patient and doctor have a consensus regarding this therapy. Again, because of this adherence, twice daily regimen could be even more favorable than one daily regimen. But it is a very complicated demonstration, and maybe with the other occasion we can discuss this aspect.
Okay, thanks so much for that. Another question that's come in. In the case of acute, less than 48 hours, that is, atrial fibrillation, what do you recommend as antiarrhythmic drug after the conversion, and for how long? So
if I understand well the question, it's not about anticoagulation, it's what antiarrhythmic I recommend from the acute cardioversion of atrial fibrillation lasting less than 48 hours. I'm correct?
Yes, that's correct.
Okay. The recommendation nowadays is, of course, Vernacalant. Vernacalant demonstrated in atrial fibrillation, but not in atrial flutter, the highest rate of conversion if the atrial fibrillation is recent. It means less than 7 days, so it entered 48 hours. Particularly, I am not at all found for amiodarone for conversion, because not only Vernacalant was demonstrated in a special trial, AmioVert, to be superior to amiodarone, but the conversion rate with amiodarone is in real life very low.
Okay, fantastic.
We should emphasize that 30% of such patients convert spontaneously.
Okay, fantastic. Thank you for that. We've got time for one more question, and that is, why are NOACs still underused in practice?
I'm sorry, I haven't listened.
Okay, I'll say it again. No problem. Why are NOACs still underused in practice?
This is a very good question. I can answer short or long. Short is I don't know.
Okay.
The long answer is probably more complicated. There are three things interfering for this underuse of NOAC in clinical practice. First is education. Not only the education about NOAC, but the education about the stroke risk. And the proof that I am right is use of aspirin instead of oral anticoagulants in many patients in different registries published these days. The situation is better now, but far from being ideal. It is for me a surprise that in many studies demonstrated in several countries and in many larger registries, doctors are not at all conscious of the value of CHA2DS2-VASc, the so simple CHA2DS2-VASc score in classification for risk of stroke. For example, patients with a very high CHA2DS2-VASc are not optimally anticoagulated because of the fear of hemorrhage. So education is an important point.
Okay.
Second is knowledge about the pharmacokinetics and the NOAC, which is a little bit linked to the conservatorism, which is somewhat typical for doctors. And the third, of course, is an economical reason, the availability of the drug on the market and the price, so the compensation of the drug.
Sure. Well, that's a very comprehensive answer. Thank you so much for that, Dr. Dan. It's been a pleasure having you with us today. So thank you very much for joining us from Bucharest, Romania.
Thank you. Thank you very much. So long.
Fantastic. Okay, so that was Dr. Dan speaking to us from Bucharest in Romania, and you can find out more about Dr. Dan in the link under this video. So it just remains for me to say thank you, our audience, for joining us today, and I'd be really grateful if you could just rate this webinar using the star rating system on your screens. And to listen to other webinars from Radcliffe Cardiology, please turn to our website under the Academy section, which is radcliffecardiology.com/academy/webinars. So that's all from me, and wishing you an excellent rest of the day. Thank you and goodbye from Radcliffe Cardiology.